I got a clinic where like most people have failed everything type thing, and I get exceptional results in that patient population. My knee pain's gone, my leg pain's gone, she had pain in her IT band. My ankle locking feeling is gone. And I'm like, totally walk around for me. She's like, yeah, no, it's gone. And I'm like, this is still SI. It's the hardest case to help is long haul SI rehab. Now, I do probably 100 rehabs a year, 100, maybe more than 100, maybe 120, something like that, of SI rehabs a year. It's basically the main thing I treat. And the long haul SI patients with inherent groin weakness, it is not pretty. I have 3 patients right now that had their spines fused and no clinical benefit. They did not feel any better. The surgeon said it was a success, and they come in here and I open up their SI joints and realign their SI joints and I rotate their sacrum back and boom, their pain's gone. And one of them is discharged. Hey everybody, what's up? Physical therapist Dr. Ryan Whelton coming to you live from just outside of the very hot Tampa Bay area. It is summertime here. It gets very hot and humid. If you're new to following me, I'm a physical therapist. I got a clinic where like most people have failed everything type thing, and I get exceptional results in that patient population. I develop methods and protocols, and I published in peer-reviewed journal a bunch of papers. On my website, you can read them, wheltonmethods.com. And I also have all my online courses. I put everything online. My instant pain relief, myofascial referral technique course. And then I have my rehab results course, which is my orthopedic protocols that I use in here. And my sciatica, cervical radiculopathy, immediate relief course. And then I have my business course. I teach people how to open and run cash-based, results-based, cash-based businesses using my protocols. And then I have my VIP, my inner circle. And soon I will be doing or check back. I actually am going to be teaching live again, but doing it online in a membership group. Okay, so check back with that. Okay, so today I am talking about a patient that I have seen 9 times and was an interesting re-eval the other day. So when I met her, she had back pain for 13 years and then pain down her leg as well. And I did my published SI eval. And her, let's see, when I asked her to extend back, I put both of my thumbs on her PSIS, the bone over here. My left thumb went down, my right one went up, which told me that she had translated superiorly. So that told me she had an upslip of the right side of her pelvis there. So I pulled under her leg, brought that back down, and then I laid her on her side and I gapped the ASIS medially. Follow me on Whelton Methods. I have a whole library of videos on how to do this, and Spotify now that you can see and watch me take you through these steps. And I was able to relieve her back pain immediately. Also, I rotated her sacrum back. She had a sacral torsion. She bent forward or did a prone press up test, and my left thumb dipped in, which told me that she had a weak right piriformis. You check that, put them in a 90-90 test, check the piriformis strength, which was weak. So I strengthened her right piriformis, and we've been doing this rehab now probably 6 weeks, I think. And so what's interesting is she, very early on, she came and she's probably week 4 or 5, my back is feeling great, best it's ever had. But when I met her, she also complained of knee pain, right? Peripatellar pain, right? So I did the Ober's test and the modified Thomas test, and they were both positive. So I stretched her IT band and her rec fem and expected that to get better. But her 9th visit was the other day. I usually see people 10 times. Her back's better, but she's still complaining of this knee pain. And then she started telling me that it hurts like in the Pezan serine area, and then down her leg, in her thigh. And then she says that my ankle locks on me, she said. My ankle feels like it locks on me. So I'm like, whoa, I missed an ankle issue? Like, whoa, what is happening here? And Obviously, that wasn't patellofemoral syndrome in the knee. So I kind of did a full stop reevaluation of what is happening here. Her back's better, but yet her leg still hurts and her knee wasn't getting better. So what I did was I rechecked myself. I always do this every visit with people. I know exactly what's wrong with them, what's causing their pain, because I get them out of pain. So I can tell, what was causing it if you get rid of the pain, right? By realigning something or whatever. So at first, I checked her knee misalignment, and I checked her ACL, her PCL, her LCL, her MCL, her, you name it, the structures of the knee. I tested it, right? And yeah, no, everything was pretty normal. Maybe a little bit lax on the right ACL, maybe. It hurt to touch on the pesi and serene, but I mean, if you push hard enough on a lot of people, it would hurt to touch there. And so I'm kind of sitting there like, where is this pain coming from in the knee? And then I went back up to the SI. She did not have an upslip, so when I asked her to do extension, standing extension, I put both thumbs on her PSIS, and when she extended back, my right thumb did not translate superiorly like that. They both dropped, so she didn't have an upslip anymore. So then what I did was I pushed medial on her in standing. I pushed medial on her ASIS like that, and I asked her, "Do you still have that pain in your leg?" And she said no. And in fact, her foot turned in where she was complaining that it was externally rotated and the other one wasn't. So she still had a flare, right? So I was like, that's interesting. That's all of that is that. But sometimes she was a little wishy-washy with some of the issues, like the ankle locking, tightness, feeling. So what I did is, because sometimes, you can do the gate control theory of pain. You can push hard on their hip, and that hurts. And then they're telling you that, oh yeah, like I don't feel it here anymore, right? But like I wanted to make sure that I wasn't tricking her brain, right? So what I did was I used an SI joint belt. Okay, now SI joint belts help if the issue is outflares. If you think about the function of an SI joint belt, you wrap it around the ASIS, and you do what I published in my paper, and you wrap it really, really tight. People, I find, don't put these on right. And you wrap it really tight, and you're trying to pull this open, the ASIS medial, and gap it open in the back, okay? And so I put on the SI joint belt, and the patient said, yeah, no, everything's gone. My knee pain's gone, my leg pain's gone, she had pain in her IT band. My ankle locking feeling is gone. And I'm like, totally walk around for me. She's like, yeah, no, it's gone. And I'm like, this is still SI. And I'm like, interesting, your back pain went away, but yet you're still complaining of leg pain, right? So I wanted to know where we are at strength-wise in her groin muscles, because I find usually after about 5 weeks or so, the upslip in the sacral rotation will stabilize, because they usually have, I call it the trifecta, hat trick. They have, I call it mechanical low back pain. I see it all day long in here. Upslip, sacral rotation usually rotates the same way with your left thumb dipping. And they have bilateral outflares in the chronic pain world, right? So I checked her upslip, no upslip, no sacral rotation. So of course we're dealing with just outflares, right? And then I wanted to see where we were at strength-wise. So I tested it was her right leg. So I tested her left adductor, and her left adductor was like 4+ out of 5 strength, something like that, right? And then I tested her right, the one that she's having issues with, adduction, and I could break her. And she's doing 15 pounds on my SI protocol. She's at 15 pounds, and I can break her. So what I realized that I was dealing with was a very atypical situation. So normally what I call long haul SI rehab. Long haul SI rehab I define as You have the three misalignments. You read my paper on my website. You have the three misalignments. You have up slip, you have a sacral rotation, and you have out flares of your pelvis, right? The up slip, the sacral rotation, it's usually stabilized at the same time. For me, 3 to 5 weeks. And then what you're dealing with is the out flares, right? Well, the out flares from groin weakness, okay? So what I did was I had the patient, so she's creeping up. Every time she hits 3 sets of 30, she went from 3 pounds to 6 pounds to 9 pounds to 12 pounds to 15 pounds. She's at 15 pounds, right? And a lot of times you see this with what I call long haul SI rehab, the people with inherent groin weakness, but it's usually bilateral. And this patient had an asymmetry. She had almost full strength on the left side, left adductor, and like 3+ out of 5 strength on the right adductor, even though she's at 15 pounds. And I could break her really easily. So that's why it was atypical, because it's usually both sides. But what you see with long haul SI rehab, these inherent groin weakness patients, is that they start to get better, usually around 50 to 70%, I find. And then all of a sudden they hit this plateau. And it's just like, and they keep going up in weight, up in weight, up in weight. And they cannot build the strength to open up their SI. But you're retesting every time they come in, and they have back pain. And let's say back pain is the aggravating motion is extension. I put a ball between their knees, have them stand and fire their groin muscles, boom, their back pain's gone. So you just confirmed it, right? That it was still an out flare causing the problem. And or you can push medial on the ASIS. So you have mechanical confirmation in front of your eyes, but they cannot strengthen their groin muscles. Now, I have a theory on why this is. It's just a theory. But these people are honestly the hardest thing I do in my job. It's the hardest case to help, is long haul SI rehab. Now, I do probably 100 rehabs a year, 100, maybe more than 100, maybe 120, something like that, of SI rehabs a year. It's basically the main thing I treat. And the long haul SI patients with inherent groin weakness, these people, I maybe see 3 to 5 of them a year, and it goes on for months. It goes on for 5 months. I had one lady 9 months just to strengthen her groin muscles enough to relieve her back pain. And I've had physical therapists in here that had it, long haul. And they're like, this is crazy. I know as a physical therapist that if I put more weight on, I should be able to strengthen this muscle. I know that, that the problem is out flares from groin weakness. Why won't this muscle strengthen? And it is really the hardest thing I do, I would say, as a physical therapist, is to try to figure out how to strengthen. These people need to keep going up, up, up in weight, but they can't go up. I tell my patients 20 pounds max at the ankle for adduction, and then above that you put it above the knee, because you don't want to torque the knee and tear cartilage in their knee, right? So use your clinical judgment. But I mean, these people go up, up, up and weigh 40. I had one lady that was doing, it took her 5 months, and she was at 45 pounds, and I guarantee you she was 95 pounds soaking wet. 3 times a day she was doing it. And it was shocking to me how much weight it took for her to do it, but she did it. She was in 10 out of 10 pain and she fixed it. So anyways, it's a very, 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 very frustrating process for the patient and for me, because here I am, I know what's wrong. I know what's wrong. I can confirm what's wrong every time they come in. I just can't get them to strengthen their groins enough to relieve their pain, okay? And it's one of those things that I actually started warning patients about before they ever start working with me, that there are these people, and that 9 out of 10, it's usually 5 to 8 weeks with me-ish. And then 1 out of 10, I tell them, they take longer, and you can't predict who they're going to be, and they have this inherent groin weakness, okay? So anyways, let me show you what I did, how I evaluated this patient. So, Annette, can you come here for a second, please? Okay, can you stand right there, please? Everybody know Annette. This is the Vanna White of physical therapy. She has been the star of these videos for the better part of a decade. Okay, so this patient had, her back pain was gone, her SI pain was gone, and her sacral torsion was gone after after, I don't know, it was our 9th session. So it was gone for a couple weeks before that. So probably 6, 7 sessions. Okay. So 4 weeks, something like that. And then she had this pain in her IT band. She had this knee pain. She had this pesi and serene pain. And then she had this locking sensation in her ankle. And I was trying to figure out what that was. So I was like, that's strange that her back pain's gone, but she's still having like no change in this. I treated her for patellofemoral syndrome because she had a tight IT band and a tight rec fem, and we stretched it, but nothing happened. So I was sitting there, I reevaluated her, and I went through this whole thing over again. And face that way for me, please. So read my paper on SI joint dysfunction. So you want to palpate the PSIS. Those are the knobs where your thumbs kind of like click over them. Okay. And I had her extend back, right? Or to arch back for me. And my right thumb did not rise. And she had the problem on the right side. My right thumb did not rise or translate superiorly, which told me that she did not have an upslip anymore. But, which I expected that to go away. So I'm like, So after I was finishing reevaluating her knee or everything, I'm like, I wonder if it's still this. So I pushed medial on her ASIS, like face this way for me, Anna. So I was pushing medial on her ASIS, and I said, is the pain still in your leg? And she said no. And but then again, I'm also pushing, and causing pain, right? Because I'm pushing right on a bone. So then I took out a SI joint belt. And when I took out the SI joint belt, I did this as a diagnostic tool to make sure that it wasn't me that was tricking her brain in the gate control theory of pain, right? So I put this around. You got to put it around the ASI. Think about what you're doing. Basically, the greater trochanters is where this thing goes, okay? So you got to pull really hard, okay? And then the extra straps that come with them, you have to pull really hard. You're trying to create an in flare from an out flare. That's what the purpose of these things are, okay? Like that. And then, so when I did that, I said, now how do you feel? And she's like, all my pain is gone. And I'm like, what about that tightness, locking feeling in your ankle? And she's like, yeah, no, that's gone. And I'm like, wow. I'm like, that's crazy. So what I had her do is I'm like, wow, this is interesting to me that her back pain went away so quick, but the leg pain is still there. Usually it's like at the same time. I got a guy right now with leg pain from SI, and then also back pain, but his back pain and leg pain are going away at the same time, So what I had her do is, it was her right leg. So go ahead and lay on your side face this way for me, please. So I wanted to test where she was at for SI joint dysfunction for her groin strength. So what I did is I said, she had almost full strength on this leg. So pick your leg up for me, please. And when you test adduction, what you want to do is have them not be able to break them, and or it bounces back up. Sometimes you're stronger than your patient. It bounces back up at you. So hold strong, and it comes right back up, right? And then I had her lay on her other side for this long haul SI rehab, as I call it. And this is the leg that she was having problems with, and she had like half strength. So break your leg up, and I just went like this, boom. And I'm like, see the problem? Thanks, Annette. And I'm like, do you see the problem? I'm like, this was atypical because you usually see it on both sides at the same time, the inherent groin weakness. And she was at 15 pounds, and I would have rated her maybe a 3+4- out of 5. And she'd been doing it for like 6 weeks. And so she's what I would call a long haul SI joint dysfunction patient. And she is going to have to go up in weight in order to get this pain to come out of her leg. But I told her the good news is this. What I tell people is this, is we know what it is. It's not a mystery anymore, because she was questioning her own sanity, because everybody she'd go to, everybody told her she was like making it up type thing, right? But I'm like, the good news is this, it's physics. If you can strengthen the muscles, you can pull the out flare in. The bad news is that this is a monumental task when these people have this inherent groin weakness, And in order to keep, one of the biggest tricks I find to keep these people engaged into the rehab is continually, every time they come in, is to show them it's their groin. It's one thing if you push on their ASIS medially, And like, they don't understand the biomechanics of that. They didn't go to PT school, right? But they'll have the pain. I have them squeeze a ball. First, they'll have the pain go in extension. I'll put the ball between their knees, have them keep their feet close together when they do this. That's important. And then I'll have them extend back, squeezing, and then their back pain goes away. And I'm like, well, what did you do? You fired your groin muscle. And I'm like, remember I told you in the beginning that it was the groin strengthener that would be the kind of last thing we're trying to do here, right? And I show them that, you fired this muscle here and it went like that and it took away your pain, but you let go of the ball and then it relaxes. And they usually feel better right after their exercises at a certain point, maybe 5-8 weeks into it. But I'm like, it just starts to relax and then the outflare happens again. So anyways, this patient has to go up and wait. But she knows what the problem is now, and she doesn't think she's insane anymore. For like, keep going to doctors, and they keep looking at her knee, and there's nothing wrong with it, and then nobody could figure it out, type thing, So it was very interesting, and I honestly think it was the first SI patient, the long haul SI patient, where it was unilateral. It was one-sided weakness, which was very atypical for me to see. It's usually both sides. They just have weak groin muscles, but to have one-sided weak was very interesting. And she had the progression of 70% better, and then it plateaued. And she has to keep going up and wait per my SI protocol. Okay, so it was very interesting. But keep this in mind, okay? And the process that I went through, not only for me to diagnose it, but for my patient to understand what's happening. You know what I'm saying? Like squeezing a ball and showing them that, like, look, you squeeze a ball, your pain goes away. What'd you do? You fire your groin muscles. Because if they become disengaged, they think, number one, you don't know what you're doing. And number two, this is 20 years of doing this. And number two, they will continue on in the process. So you can't lose their engagement. Otherwise, if they quit, that groin relaxes and then, it loses its strength, and that outflare jams again, and they got back pain and they got the whole thing again. Okay, so it's important to keep showing them as they go through this process. But I would say the most important thing is to actually warn them ahead of time that people like this exist. Okay, because when it happens, when I didn't warn people, people thought I didn't know what I was doing. But when I started to warn people that these people, they're maybe 1 out of 10 people that have this inherent groin weakness when you do SI joint dysfunction rehab using my protocol, that they just take forever, like they take months and months to fix, to stabilize it, okay? And if you don't warn them about these long haul SI patients with inherent groin weakness, then after about 5-8 weeks, they think you're nuts, and you didn't know what you were doing, and then they quit, and then they go into the medical system. And if you do SI like I do, you know exactly what happens to those people in the medical system, and it is not pretty. I have 3 patients right now that had their spines fused, and no clinical benefit. They did not feel any better. The surgeon said it was a success, and they come in here and I open up their SI joints, and realign their SI joints, and I rotate their sacrum back, and boom, their pain's gone. And one of them is discharged. Yeah, as of yesterday, is discharged. Totally better. Got better in 5 weeks after over a decade of this and a spinal fusion surgery that failed. So anyways, that's that. Peace. Love you all.